Hi, everyone. Welcome back. Thanks for your patience there, just figuring out a few things behind the scenes. Once again, my name is Tina Costa. I'm a director with the Office of Virtual Health. I will be your host for all of these virtual sessions. You'll hear me say this multiple times. It's my pleasure to welcome you or re-welcome you back to this session, which is part of the 2023 BC Digital Health Forum, inspired by Canada Health InfoWay's Digital Health Week. For those of you just joining our virtual circle, we encourage you to share in our collective gratitude for the opportunity to come together from many traditional, ancestral, and unceded territories of BC First Nations. May we all take pause to honor their connection to this land, their stewardship in caring for and nurturing these lands for all time. And as always, let us give thanks for the opportunity to gather, learn, collaborate, and provide care on these beautiful lands. It is now time for our Pecha Kucha presentations, which are a series of rapid fire presentations. Throughout the next hour, you're going to see 6 fantastic presentations. Just a quick note that due to the nature of Pecha Kucha, we're going to save all of the questions until the end. However, feel free to submit your questions throughout so you don't forget them in the Q&A. Speakers will be invited to submit answers in the Q&A section, but otherwise we'll wait till the end and ask a few in person and have our speakers answer them. As I mentioned also, if in the event we can't get to your questions that are in the Q&A, please encourage everyone to connect with the speakers via the networking app or tab, sorry, on FeedLoop. Okay, I'm going to take the honor to introduce our first presenter, Hira Aziz. Hira is a leader with the PHSA Office of Virtual Health. Hi, Hira. She's a virtual health enthusiast with a background in project management. She has a bachelor's of psychology from UBC and is currently enrolled in the Master's of Health Administration program, also from UBC. Please join me in welcoming Hira for a presentation on Are We Speaking the Same Language? Partnering on appropriate virtual care with linguistically diverse patient partners. Over to you, Hira.
Thank you, Tia. Hi, everybody. I am here to talk about a project that I'm co-leading at the Office of Virtual Health and share a few of the many lessons that we learned engaging with patient partners from linguistically diverse communities. Before I begin, I would like to acknowledge that I am joining here as an uninvited settler from the traditional, ancestral, and unceded territories of Kwantlen, Katsi, Matskwing, and Simeamu First Nations, also known as Langley. Here is a quick snapshot of our agenda that we'll cover in the next 6 minutes to be exact. Starting with our project overview, Partnering on Appropriate Virtual Care is a collaborative between Healthcare Excellence Canada, which is a pan-Canadian organization, and PHSA, specifically Provincial Language Services, and the Office of Virtual Health. In this project, we aim to create resources that promote safe, high quality, and culturally sensitive virtual health interactions between community members and healthcare team. Language access and equity is a very evident gap that is present in our current healthcare infrastructure. Therefore, in this project, we will specifically focus on needs of linguistically diverse communities in a virtual care setting. Here is our amazing project team. To truly incorporate an informed lens into our project from those with lived experiences, we have a co-leadership model. Our project is co-led by a patient partner, and also Scott, who is a language access lead with Provincial Language Services and also from the deaf, blind, and hard of hearing community. In addition to that, our project working group includes members from various different language constituencies, including patient partners from Spanish, French, and Indigenous deaf, blind, and hard of hearing communities. The focus on language access and equity, it is truly groundbreaking. We had to navigate a lot of new waters that came with a lot of lessons learned, or what we call them reflections. And I hope to share a few of them today to really shape the future of our patient engagement in embodying a truly diverse and inclusive approach. First off, extra time. Be open to build in extra time into your project timelines and meetings. Incorporating language access and equity lens into your project could be challenging, will be challenging. We ran into quite a few challenges managing multiple different simultaneous interpreters in a meeting. If you have various different patient partners involved, they may have different timelines than you, so be flexible. Let go of the corporate mindset might be a hard pill to swallow for many of us, but to truly invite transformation, we have to change certain ways of doing things. If you want to engage with partners, start as early as you can. If you are involving patient partners throughout your project, start at the ideation phase, put out proper expressions of interest, create standard onboarding packages outlining their expectations. If you want to consult with various partners through your project, connect with them as early as you can, because getting the response from the right person could potentially take days to weeks. In terms of tools of collaboration, currently within PHSA, our tools of online collaboration are not really optimized for external partner engagement. So if you really want to give patient partners a platform to provide feedback, review project documents, work with you through it, we really need to modify our current platforms and open up these silos that we have. Digital literacy will also vary across your project with multiple partners involved. If you have patient partners, ensure you're scheduling separate onboarding meetings with them ahead of time and ensure that they're comfortable with the tools and technology that you will use throughout your project. Interpreters will also have varying levels of literacy in terms of using the Zoom interpretation functionality, skill set, work with provincial language services and their coordinators. They're amazing. Try to schedule prep sessions with interpreters ahead of time. I understand these are added administrative steps, but they will truly ensure that your actual meetings run smooth and are as productive as they can be. Lastly, money. I just want to be very transparent. Incorporating language access and services in a project and partnering with various different patient partners from different language communities, it could be costly, time-wise, money-wise. Some interpreters could cost as high as $300 per hour of engagement. Translation costs vary depending on the word count. But I think of it this way, short-term costs for sure, but long-term benefits in terms of improved patient satisfaction, improved patient empowerment, and potentially improved outcomes that will lower our downstream health costs from disease complications or return visits. In terms of what's next, our project is still underway. Before we create our resource, we really want to engage and hear from those who are directly involved in healthcare, meaning healthcare team, community members of patients and caregivers. So for our next steps, we will be engaging with healthcare team through focus groups and survey, all done online. Currently, we are registering people for focus groups, hoping to start them by next month, and the surveys planned for next year. Similar timeline and approach for patient partners and caregivers, focus groups or interviews starting next month, and surveys next year. And that being said, if you have anybody that you feel like might be a good fit for this project or be interested to engage with us through surveys, online focus groups, or interviews, please connect with me. I will put my email in the chat. And to end us off, I have a message from our patient partners who recently immigrated to Canada from Colombia. The message is in Spanish, but I do have transcription at the bottom for everybody.
Hola, soy Cristian Díaz.
Y yo, Lina Barba.
Desde hace aproximadamente 4 meses estamos participando en el proyecto de PBAC como Patient
La
Partners.
invitación a participar en el proyecto nos llamó mucho la atención, el objetivo del proyecto y la importancia que le daban al punto de vista del paciente, que es el que finalmente recibe la atención.
Nosotros hemos tenido diferentes experiencias de atención médica, tanto virtual como presencial, en diferentes países como Colombia, Perú, España, India e incluso Canadá. Y hemos compartido toda esa experiencia, todos los detalles y ese conocimiento dentro del proyecto. Muchas gracias.
Muchas gracias.
Hola.
And that brings me to the end of my presentation. Thank you, everybody.
Thank you so much, Hira. A great way to start off our presentations, our Kucha. I'm messing it up already. Our presentations today, lots of really great emojis coming your way. I'm going to quickly hand it over and get ready for our next presenter, Christy Boyce. Christy was a critical care respiratory therapist and certified respiratory educator for 17 years, working at BC Women's and Children's Hospital and throughout Fraser Health. She has a vast range of clinical experience, including neonatal, pediatric, and adult critical care populations, pulmonary diagnostics, respiratory education, and home care. In 2018, Christy completed her Master's of Arts in Learning and Technology from Royal Roads University and joined the virtual health team at Fraser Health. She's still with Fraser Health, the virtual health team, in the role of leader, and is truly paving the way for best practices in digital health education for staff, patients, and families. Please join me in welcoming Christy for a presentation on Nothing About Me Without Me, Transforming Healthcare Education Using Concepts of Patient Partnership, Empathy, and User Experience Design. Christy, over to you.
Thank you, Tina. Nice to see you. I'm just going to open up my slides. Are we good? I hope you can all see them. Good morning, everyone. The title of my presentation, as Tina announced, is Nothing About Me Without Me, Transforming Healthcare Education Using Concepts of Design, Empathy, and User Experience. Tanshe Kia. Hello, how are you? My name is Christy Boyce, and I was born and raised in the lower mainland of BC, living, learning, playing, and riding my horse Shaheda all over territory that was once under the care of the Coast Salish people since time immemorial. I identify as Métis. I am a registered member of the Métis Nation of BC, and I am a member of the Surrey Delta Métis Association. My heritage is Métis on my maternal grandmother's side. Now, if you know anything about Métis people, you may know that it is our women that stand out as uniquely strong, vocal champions for our values and culture. I attempt to hold up those strong values as we unpack a healthcare system built through a colonial lens. When I was 6 years old, my sister and I were so excited when my stepdad built us a set of nested bunk beds for our room. He tried to give us something that would make the shift to sharing a room a bit easier because our family was welcoming a new little brother into the home. We loved the idea and the look of the beds, but after one running leap onto them, we discovered that the design of the side rails was too high profile, and we were instantly yowling in pain. The bottom half of my bed was always rolled under my sister's, leaving me with half of the play space, and I could never quite tuck in the bottom half of my sheets without banging my head. I don't remember the great sleeps I had in my bed. I only remember the bruising it left on my shins and my hips. This is not an actual photo, but fairly representative of what I was dealing with. The build of the beds was rational, and yet a hurried design left no room for cycles of improvement or design consultation with the youngsters in the home, leaving the users with a poor overall experience. Fast forward to my adulthood, I was a critical care respiratory therapist for 17 years, but then my interest in design of healthcare services was piqued as the world tilted during COVID-19. My context of redesigning patient education for virtual delivery was a unique opportunity to engage with users and optimize design. So how did we redesign, co-design, and transform with impact and positive effect, with meaning? How do we examine power structures and lift up voices that have long given up on being heard in the field of healthcare? We do this by upholding the concept of nothing about me without me in healthcare service design. In our virtual health education team, we connect, create trust, listen to understand. We create safe spaces to play with new ideas that will drive redesign, a human-centered approach. We aim to improve experience, adoption, and engagement with those services. So far, we've used three methods to guide our education transformations in this type of work. Those are the principles of design thinking, user experience design, and an approach similar to experience-based co-design. Now, some of this was intentional. Some of the use of these methods just happened as we led using our hearts to connect and our ears to listen, stumbling unknowingly into existing methodologies that were supported by research, as was the case with experience-based co-design. So design thinking. The 5 stages of design thinking, according to Stanford's D School, are empathize, define, ideate, prototype, and test. To empathize, we research our users' needs. We seek to understand or feel what another person is experiencing from within their frame of reference. To define, we clearly state our users' needs, barriers, and enablers. We ask what matters to you and push to support those values. For learners, this often includes things like social learning opportunities with peers. To ideate, we challenge assumptions and create ideas using safe spaces for conversation. And together we chip away at the way it has always been done. Next, user experience design. otherwise known as UXD. UXD is a process of creating digital products that requires constantly validating your assumptions of your design through user research. Get to know them, understand their needs, know what they want, and uncover hidden insights. In our redesigns, we asked in one particular case, how might older adults navigate Zoom live learning sessions? And we tested it out. If representative users are not part of the design experience, you are not practicing UXD. And lastly, experience-based co-design. This process has been around for many years in the realm of quality improvement, beginning in the UK. In short, the process requires staff and patients to work in partnership using interviews, group discussions, and observations to identify key touch points in the patient's journey and assign positive or negative emotions to them. You discuss the findings as a whole, and together you choose what to focus on for improvement. People are often changed in this process as they listen and learn. As an example, providers may see areas where they have chosen an easier process path for themselves, such as offering healthcare education for working age citizens in the middle of the workday, requiring them to take a vacation day. Our three approaches are layered onto strong foundational collaborations with patient partners and the use of patient journey mapping and empathy mapping wherever possible. Patient partnership needs to be a common practice when you're designing new digital and virtual care services, where technology acceptance and adoption require informed design. Human-centered healthcare education and service redesign aligns with tenets of anti-oppression, justice, equity, diversity, and inclusion, as well as decolonization, as we scrutinize the way things have just always been done. Understand who is in control and who holds power at every step of a process, who is not represented. How might we share this power or even give it away to open up citizen choice, autonomy, and justice? Slow down, listen, learn, reveal, reflect, and recreate. Embody these necessary and required behaviors of a learning health system. In summary, healthcare technology services and education redesign that captures patient needs, goals, and values can be truly transformational. We may never create something that's perfect for all citizens, but if we design in consideration of nothing about me without me, we are sure to cause significantly less bruising, more opportunities for healing, and a better patient experience. Thank you.
Sorry, thanks, Christy. I'm chatting by myself here. Just really want to commend you for, again, really focusing on the patient and family. Really appreciate that theme moving forward. We're going to move on now to our next presenter, who is Hira. Hira worked as a registered nurse for over 10 years in a variety of roles, spending the majority of her time working at BC Children's Hospital, primarily in oncology in the neuromuscular clinic. Hira is passionate about improving access of care for patients, enhancing collaboration, improving the patient and provider experience, and empowering patients and families to become active participants in their own healthcare journey. Hira transitioned to the Office of Virtual Health in the role of clinical leader and is working with clinical programs across the province to identify opportunities for growth, support the adoption and integration of virtual health, and to develop strong relationships and partnerships to collaborate. Please join me in welcoming Hira for a presentation entitled Transitioning to Virtual Health Lessons from BC Children's Hospital During the COVID-19 Pandemic. Hira, over to you.
Thank you so much, Tina. I'm just going to try to get my presentation ready here. Okay. Hello, everybody, and thank you so much. I'm so happy to be here today. Today, I'm going to be providing a personal reflection from my experiences as a nurse clinician at BC Children's Hospital when our clinic team transitioned from in-person to virtual visits during the COVID-19 pandemic with approximately 300 pediatric patients and their families. I just want to take a minute to acknowledge with gratitude that we are gathered on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nation, who have nurtured and cared for the lands and waters around us for all time. I give thanks for the opportunity to work, live, and support care here. The COVID-19 pandemic was certainly one of the most challenging and demanding times. However, this crisis prompted an extraordinary surge in virtual health initiatives, rapidly expanding access to care, providing new opportunities to enhance collaboration, and above all, ensuring the safety of British Columbians. We have the opportunity now to reflect on the exceptional growth of virtual health and experiences of patients and providers in order to draw valuable lessons that will guide us towards continuous improvement. The BC Children's Neuromuscular Clinic is a multidisciplinary clinic providing care to patients and families across BC and consists of a pediatric neurologist, nurse clinician, social worker, physiotherapist, occupational therapist, and dietitian. I am extremely grateful for this passionate group of people I had the privilege of working with. Despite all the challenges our team faced, we always came together and worked towards providing the best care for our patients. The patients seen in the neuromuscular clinic have a variety of neuromuscular disorders and often require supportive equipment, complex treatment plans, surgical interventions, and a collaborative approach from multiple specialists and care providers. So bringing us back to 2020, we all remember how difficult this time was. People were scared, isolated, and our healthcare system was completely overwhelmed. We had to act fast and improve access to care for our patients. We had to bring care to the patients and families that could not come to us. But how could we transition from our 8-hour in-person clinical visits to a 1-hour virtual consult with multiple care providers online simultaneously? It was time to take action. We prepared for effective virtual visits by transforming the way we delivered care. So how did we do that? First, we prepared our patients and families for effective and meaningful virtual visits. Everything from accessing a Zoom link to understanding what to expect and how to prepare. As some patients did not have internet access, we partnered with community health centers across BC to facilitate this connection. This offered an opportunity to educate and partner with the providers closest to our patients. Second, we put our patients at the center of our care. We engaged and collaborated with our patients and families first to identify their priorities. Through phone calls and emails, we gathered information prior to virtual visits to find out what was most important to them. We came together to collaborate as a team. We reviewed our patients' priorities and goals of care, and from there we strategized on how to deliver care that was meaningful, effective, and patient-centered. This time was difficult for our patients, but also extremely challenging for our providers. With staff shortages, limited desk space, and increased workload, our providers had to collaborate and work together to support each other. So what did we learn from all this? Delivering care virtually was not only possible, but it also offered new opportunities to deliver care safely, to collaborate with patients and families, to streamline care, and in some cases, to improve health outcomes for our patients. Virtual visits offered a new perspective into our patients' lives. Observing patients in their own spaces allowed for a more comprehensive understanding of their lifestyle, potential barriers to care they might face, their specific needs, and enabled our team the ability to offer more specialized and holistic care plans. We noticed that some patients felt more comfortable outside of the traditional clinical setting, which enhanced our connection between patient and provider. Our team wondered about building online support groups for our adolescent patients or parents with newly diagnosed children. Virtual visits improved access to care. For our patients in remote areas of BC or areas with limited access to support and resources, and for our patients with mobility challenges and increased risk of infection. Virtual visits provided the opportunity to reduce financial burden related to travel and time off from work for parents, therefore ensuring financial constraints did not impede on equitable access to care. Virtual visits provided the opportunity to enhance collaboration. Our clinical team was able to share data in real time, avoiding repetition and redundancy for our patients. We also began to invite key partners on the patient's care team directly into virtual visits. Suddenly, we had teachers, social workers, and community care providers involved in the discussion and planning. This collaboration and connection improved continuity of care and supported our patients to live, learn, and play to their full potential. Finally, we empowered patients to be their own heroes. We built individualized and meaningful partnerships with our patients by prioritizing their needs first and building trust. We delivered care based on what and who mattered most to them. COVID-19 was one of the most challenging and demanding times for all of us, but we came together for our patients. Healthcare is full of passionate, innovative, and dedicated people, but the key to transformation is through connection and partnership. I encourage you as leaders in healthcare to come together, collaborate, and listen. Listen to the patients and providers who have experienced the barriers of care firsthand and have valuable insight on opportunities for improvement. Remember what matters most, challenge traditional methods of delivering care to patients, embrace innovation, and continue to work together towards a more connected healthcare system that prioritizes patient-centered care and ensures equitable access to care for all British Columbians.
Thank you, Kara. It's great to see all the little people on your slides. That's fantastic. Thank you so much. We're going to keep moving on. Lots of emojis for you at the bottom of the screen. We'll now move on to our next presenters, which you've got a duo coming up, including Claire Doherty and Isabel Angwa. So Claire is the manager for virtual health for Providence Healthcare. He works with health professionals and software vendors to improve patients' access to high quality healthcare. The virtual health team enables clinical teams to use digital solutions for virtual visits, questionnaires, interpretation, remote monitoring, text messaging, and more. Claire's career history includes leading quality improvement projects, enabling family physicians to learn from their electronic medical record data, and conducting research. Isabel is the virtual health specialist for Providence Healthcare, working with clinical teams within PHC as they integrate virtual health tools into their workflows to meet clinical needs and requirements. Isabel has an educational background in biomedical sciences and health informatics and holds several other certifications in IT and data analytics. Her professional journey encompasses diverse roles within healthcare, information technology, and business analysis. She's contributed to projects involving designing of user-friendly interfaces, identification of areas for improvement within business processes, and implementing solutions to enhance patient care across virtual health platforms. Please join me in welcoming Claire and Isabel for a presentation on bridging care gaps, how digital innovation is reshaping patient care and outcomes. Claire and Isabel, over to you.
Great, thanks so much, Tina. I'll just share my slides here. All right, so hello everyone. As Tina mentioned, I'm the manager for virtual health for Providence Healthcare. My co-presenter is Isabel, who is the specialist for virtual health at Providence. Our topic is bridging care gaps, how digital innovation is reshaping patient care and outcomes. We'll be speaking with you about 4 digital health solutions that are used at PHC. They're all represented here on the slide. The top left image shows appointment reminders. Point of care ultrasound is at the top right. Clinical digital messaging is at the bottom left. And the bottom right image shows clinical digital questionnaires. This is Julia. A clerk on the phone is telling her that she has a pulmonary function testing appointment tomorrow. This doesn't work for Julia's schedule. The clerk says that she should have received the appointment details from her family doctor's office months ago. Unfortunately, Julia never received these details. She now needs to wait months for another appointment. This is Jeff, a respiratory therapist. Because of the miscommunication about Julia's appointment, he has an empty slot and it's too late to book another patient. This contributes to long wait times and can delay diagnosis and treatment for patients. It's also frustrating for Jeff when his time isn't used effectively. Thankfully, the pulmonary diagnostics team decided to implement automatic appointment reminder text messages. The next time Julia needs pulmonary function testing, she gets a text message as soon as her appointment is booked and receives reminder texts as the date approaches. This time she's able to plan ahead and she arrives on time for her appointment. The rate of no-shows for pulmonary function testing has declined and the late cancellation rate has also gone down. This means shorter wait times for all patients. Jeff is happy that his work days are now flowing more smoothly and predictably, and he's able to help more patients get diagnosis and treatment in a timely fashion. Next, I'll tell you about point of care ultrasound. Oscar is a resident of Dodging Geeds in Haida Gwaii. One morning, Oscar wakes up with chest pain. He's worried about his heart, and so he goes to the Hira Hospital and Health Center for emergency care. The emergency physician, Dr. Lee, performs an echocardiogram using point-of-care ultrasound, which is also called POCUS. He doesn't see anything that makes him concerned, but he wants a second opinion from a cardiologist. He uploads the ultrasound clip to a cloud-based viewer. He then opens the Rapid Access to Consultative Expertise, or RACE app, on his smartphone and requests a consult from Dr. Rob Moss, who is located at St. Paul's Hospital in Vancouver, which is about 1,000 kilometers away from the Hira Hospital. Dr. Moss reviews the images and agrees that there are no signs of problems with Oscar's heart. Dr. Lee and Oscar are reassured, and there's no need for Oscar to travel to a major urban center in order to see a cardiologist. Dr. Lee proceeds with examining Oscar for non-cardiac causes of chest pain. I'll now hand things over to Isabel to present on 2 other solutions.
Thanks, Claire. Our next solution is digital automated messaging. Meet John, an ambulatory pharmacist at St. Paul's Hospital. He's required to offer counseling to patients when the prescriptions are refilled. He does offer counseling by calling the patients and answering all the questions that they have regarding the prescription. And here we have Nancy, a patient in Northern BC who receives medication refills by mail from St. Paul's. She's very frustrated because she gets so many calls and sometimes she doesn't even know who called because she doesn't have her voicemail set up. With the introduction of our clinical automated messaging, she's able to accept or decline a pharmacist consult. She's also able to control when to take calls and ask questions regarding her care. The pharmacist is also able to use the Memora dashboard and see which patients need follow-up calls based on their responses. Thereby, he's able to have much more time to care for more patients, and Nancy now has full control of the pharmacy phone calls that she receives and can provide consent when she wants. Nancy is also able to follow up with her pharmacist on medication refills and any updates on her personal information. Our next solution is going to be digital patient questionnaires. Meet Amir, a patient at St. Paul's Hospital who comes in for his appointment. The clerks state that he needs to complete health history questionnaires before proceeding. Aside from his physical discomfort, it's overwhelming to fill out multiple paper forms under a time restraint. As he starts to complete the forms, he feels constrained trying to convey medical history, symptoms, concerns within the small fields on the paper forms. He's also frustrated as he's required to provide the same information repeatedly on different forms, so he decides to complete whatever he can and he leaves much of the spaces blank. Having to struggle with reading ineligible handwriting and receiving incomplete forms, the nurse is also frustrated, as this means he has to follow up with patients and the healthcare providers to get more information. He needs to spend additional time managing paperwork, which could otherwise be used for patient care or other essential tasks. With the introduction of clinical digital questionnaires, Amir is able to complete his forms at his convenience using his phone or maybe his laptop or computer. The clinicians are also able to review patient information submitted from the dashboard even before the appointment. This saves a lot of time even before the patient arrives, and Amir also has a chance to view the information submitted, thereby reducing errors and streamlining clinical workflows.
Thanks, Isabel. To recap, Isabel and I have spoken about 4 different digital health solutions that are used at Providence Healthcare: appointment reminders, point-of-care ultrasound, clinical digital messaging, and online clinical questionnaires. These solutions have bridged gaps in care, helping to improve outcomes, enhance experiences, and avoid unnecessary costs. Thanks so much for listening.
Thank you so much, Claire, and thank you so much, Isabel. A great presentation and great examples of the different technology that really provides holistic care. Going to switch over to our next presenter, who is Rachel Bartholomew. Rachel is a two-time entrepreneur who is now working on her second company, High Ivy Health, created after her recent fight with cervical cancer. High Ivy Health is creating a pelvic rehabilitation device for the 1 in 3 women worldwide who will experience a pelvic health complication in their lifetime. Rachel is a graduate of the University of Waterloo and has been working in various roles in the entrepreneurship ecosystem for over 15 years, including the founder of Femtech Canada and professor at Toronto Metropolitan University in biotech innovation. Please join me now to welcome Rachel for a presentation, as you see it here, Data as an Innovation Bottleneck, a case study on women's health. Welcome, Rachel.
Thank you, Tina, and thanks everyone for having me. I'm here to talk about the one thing that's holding us back from innovation in women's health, and that's data. Did you know that many of the data sets that we interact with in healthcare are wrong? They're incorrect representations of public health and do not accurately represent our total population health in Canada. That's because 50.4% of our population in Canada is female. But yet, Canada didn't mandate for women to be a part of clinical trial research and activities as participants until 1997. That was 30 years ago. This is after the 3 years that US mandated that women should be included in clinical trials. This is because in 1977, policy was created to exclude women of childbearing potential from phase 1 and early phase 2 drug trials, even if they used contraception, were single, or their partners were unable to conceive. During this time, women lacked in the working fields of medicine and science, and women's health needs were considered a low priority in these fields. In 1993, the US finally made the inclusion requirements stricter in their NIH-funded research to include women and minorities into all clinical research. This means that the majority of the drugs and devices that have been cleared between 1970 until 1990s have largely only been tested on men. These drugs and products include the likes of certain opioid drugs like tramadol, HIV antivirals, many anti-inflammatories like NSAIDs, Flonase for asthma, and even propofol, which is a formulation used for anesthetics, just to name a few. Women were often replaced with skinny males to substitute the lack of women in trials, and basic requirements for fundamental research were not met. For example, in the study in 1986 looking at the effects of obesity and the relation of that obesity to uterine and breast cancer, no women were actually a part of this study at all. This ultimately means that many of the treatments that have been developed do not have proper efficacy and safety data in the female patient populations, leaving us 20 years behind in data collection for women's health. So how deep does this gender bias and lack of female representation go? Well, it's been reported that only 17% of animals tested in labs for first animal studies before drugs and devices go into phase 1 trials are on female animals. Then when we move into the next step in clinical research, the phase 1 trials, there were only about 36% of participants who were reported included in these trials were female. As we move out of research into condition-based reporting, women are nearly twice as likely as men to develop Alzheimer's disease. But yet 12% of our federal funding on Alzheimer's disease goes towards women-specific research. We also know that cardiovascular disease is the #1 killer in women. We not only have completely different biology than men, but we actually experience differences in cholesterol buildup. We present different symptoms than what is actually taught to us as symptoms of a heart attack. We have different risk factors. We actually have diseases that women are more likely to experience that actually mimic heart attacks. But yet, 1 in 3 participants in cardiovascular research are female. It has been clearly stated that women are under-researched, under-recognized, underdiagnosed, undertreated, and undersupported in cardiovascular disease and beyond. Yet it has been proven that when we double the budget towards research in women's cardiovascular disease, it has been projected to save nearly 20,000 lives annually. With all of this being said, women's health research in Canada out of the CIHR, the Canadian Institute for Health Research, accounts for 5% of funding over the past 12 years. The CIHR has 3 times as many male-favored diseases being researched to female favored diseases, with funding 2 times as large for male-favored diseases to that of female-favored diseases. And with a 0.1% improvement on women's health outcomes, there's a return on investment of 9,500% just by doubling investment into women's health research for all diseases. For the CIHR, that means a budget double from 20 million to 40 million out of a $1 billion research pool. So after all of these statistics, where do we stand in applying technologies like artificial intelligence and machine learning in healthcare and digital health solutions? This chart is a full representation of where we're at in this conversation. A heightened interest in new technologies with stagnant interest in women's health overall. How can we apply new technologies to digital health and beyond when we're so far behind in collecting a novel data set that's equal in representing population and public health? Here are some of the ways that we can change this narrative and start with this groundwork needed to build these amazing technologies while advancing women's health. The first is to push for equality in animal and phase 1 trials while also reporting sex in all of your research. Currently, only 31% of papers actually report sex. Secondly, we need to move towards equal funding in women's health, specifically funding trials that close the gender gap in fundamental research. Third, we need to prioritize data collection in women's health research, whether it's breakthrough science, small improvements, or innovative solutions. Women need to be included in baseline recruitment strategies. And finally, we need all researchers, innovators, and companies to review their data sets that they're running their analysis on while rethinking the metrics we use to analyze that data to move towards better equality. To conclude, to address women's health inequality, it must first be measured, and data is the key importance to closing the gender data gap, advancing technology, and keeping women safe in the healthcare that they receive. Thank you so much.
Thank you so much, Rachel, and thank you so much for your continued advocacy. Now we're going to move on to our final Pecha Kucha presentations. I said it right this time, and it's my pleasure to introduce Simi Callan. Simi is the Director for Clinical Education with PHSA. She has 20 years of experience as a critical care nurse, including over 10 years in education and leadership. She graduated from the University of Victoria with a master's degree in nursing, focusing on education in 2020. Simi is published in many peer-reviewed journals, including the Canadian Journal of Critical Care Nursing and the Comprehensive Healthcare Simulation Textbook. She works as a simulation faculty for the Extracorporeal Life Support Organization, as well as an instructor for Heart and Stroke Foundation. Welcome, Simi. And here is her presentation on technology, the future of healthcare education. Over to you, Simi.
Thank you so much, Tina. Hello, everybody. I'm so glad to be part of this this amazing week. And I just want to gratefully acknowledge that I am joining today from the traditional and unceded and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, who have cared and nurtured this land for all time. As Tina mentioned, I'll be talking a little bit about technology, the future of healthcare education. However, I think that's probably already here a little bit, and many of us are doing many of these things. So my presentation is just a bit of a call to continue to incorporate tools and technology as much as we can into education to support a really good learner-centered approach. So let's talk about some myths that may exist first. So there's many myths that exist around using tools within education, that there will be digital distractions for our learners, unequal access for our learners, they may widen our achievement gaps, and that there's limited evidence. And I feel that many times as educators, it's difficult to embrace technology because it's hard for us to have time to learn it. It's difficult to sometimes find which one do I want to use, and also where do we get the funding when we need it for various pieces. This is a quote that I really love by Matea Harvey, who's an American poet. Teaching is a great way to keep learning. And again, this is just really a call for everybody to, sometimes get a little uncomfortable and start to use tools that we may not be comfortable in, but can really enhance our ability to engage our learners in a virtual way or in a classroom, and really engage them and pull on so many of the neat pieces that can be available for our learners. So tools enhance learning. They support design of education. They can support team-based learning, interprofessional learning, and intergenerational learning, and actually improve some of those intergenerational learning gaps that exist. They can provide flexibility and personalized learning opportunities, and increase accessibility to education, which we'll talk a little bit more about as well. And tools are really embedded within our adult learning principles and really pushing to enhance our healthcare education that exists. So educational design, many times when people think of designing education, we don't necessarily think of engaging technological tools. However, I would argue that there are many available, and sometimes it's just the way that we think about using them and how we can design our education around it. Some of those tools are really showing up in our AI world. And as you can see, the papers since 2010 to 2019, and I wish I had data up to current, but because it's only exponential since. But really, when we look at papers that have been published around AI and education, it's really just starting to enhance and grow. We're starting to see AI as a really kind of regular port of medical institution education, and it's really starting to show up elsewhere. As generally people think of it as a negative, and that was really what was kind of coming out with ChatGPT earlier on in the year, but it's really starting to look at it and embrace it from a different perspective. The other interesting thing that I think is really happening is that we're starting to have AI and its use in education show up in different theoretical underpinnings of education. So constructivism, behavioralism, and then how do these different types of theories actually lend themselves to the use of AI, and then having AI now developing their own theoretical paradigms that can support us in our ability to use and enhance education. AI is a great way to develop case scenarios, to develop interdisciplinary scenarios that maybe as a nurse, I may not know how a physio may respond, but I can put something in and then see what pops out. It's also a great way to ask, how can I do evaluation differently? How can I engage learners? I need an interactive design. And so there's really different ways that you can engage AI to develop your educational designs. Another way to look at educational design is simulation. And, simulation, we kind of think of it as healthcare, as we get into a room that's set up really cool, fancy stuff. We get in there and we do a bunch of things. However, there's actually many different ways within the digital or virtual world that we can do simulation. So, it can be as fancy as and expensive is what I like to say, as virtual simulation, where we have VR goggles and the software that's required to do that. Not necessarily always possible within a public healthcare system because it is very expensive. And then there's also remote simulation, where a learner may be able to go into, we can have essentially remote simulation software that we plug case scenarios into, and then they respond to the way the learner walks through them. So that can be done anywhere as long as there's access to software. There are also other types of simulation software where people can, there's essentially a tech that's running a bit of the controller dashboard, and then learners are participating in another virtual platform and observing their facilitator essentially doing some of the actions. And then they get to choose what are the actions that they're going to do. And then the tech will make those vital signs changes. So that's another way of looking at how other software can be used to develop different educational designs. Then there's really low fidelity, and honestly, the one that I've probably used the most, especially in my previous roles, which was kind of like this telesimulation, where we had learners sign in through a Zoom platform. they observed us and we sat elsewhere, our tech sat and made the changes to the mannequin. And so this really what required is us to just get equipment to where it needed to be, but the learners could be anywhere and we can all engage and learn. And an AI helped us build our scenarios and all of the pieces that we needed to go with that. Another way technological tools can really enhance our education is really looking at the team-based learning overview. And many of us, we try to learn everything we can all at once, but we know that that's not the best way to retain learning. And I think in healthcare, the other big piece is we really want to improve ability of learners to do that critical thinking, that clinical reasoning that we really need staff to be thinking about when they're faced in real life scenarios. And so, really focusing on this application portion is where the technological tools, I think, come in really handy, so that they've done a lot of what they can up front. And now it's like, let's try to get through some of these scenarios together and really improve our learning. And of course, simulation is a great way to do that, which we've already talked about, but there are other ways that we can do that if we don't have access to sim. One of those ways is a platform that I really like to use and incorporate into my learning designs are Padlet. So Padlet is essentially a digital bulletin board. You can have rooms in there. People can write down on their Post-its. It's really a link that you set up and then share in your chat, and then anybody can sign in. It's also can be used in a classroom session where they can do a QR code and essentially join. But people can do work in groups this way. They can actually do presentations in groups this way. You can get direct feedback and almost like a bit of a polling session as well. So Padlet is a great online tool if you've never used one to kind of dabble with. You can do a free version as well, which will give you a certain number of boards essentially that you can use. Additionally, many of us know about these is our online polling pieces like Mentimeter. Poll Everywhere is a completely free resource that we can access. Mentimeter doesn't have as much, but you do need a little bit of a subscription. And then there's Slido as well that we're pretty familiar with. And again, this is a really great way to get immediate feedback from your learners if you're trying to see, is what I'm saying hitting home? People can give anonymous feedback. They can also, you can participate in group work this way. And it's a really nice way as a facilitator to collect some data, especially in a virtual platform where you maybe can't see everybody, but you can at least understand, okay, what are they learning from this? What are they taking away from it? And where do I still need to do some work? Of course, these ones are very familiar. There's the Jamboard, which is a digital whiteboard. The one that I recently learned about was Zoom, which has an annotation capacity to it, which I was like, oh, this is so wonderful. But it's another way to, again, engage with low-cost interactive tools that can really promote that team-based learning, that application learning, critical thinking, and clinical reasoning. I mentioned some of these already, but again, for curriculum designs, you can use ChatGPT. We use this quite frequently for our new grad transition to practice program that we've started here to develop scenarios using all different types of disciplines. I've never worked with a radiation therapist, for instance, and I was like, I don't know what kind of scenario I would use for that. So we could develop something and then get it validated by the right person. Canva is a free tool as well, which has some great kind of like newsletter platforms. It can make some presentations really interesting and engaging. It allows you to download videos into it. And then Genially is one that I've come across frequently, and it's actually a really neat gamification and learner experiences board, which has some free capacity to it. And then you would need a bit of a subscription if you needed a bit more. This one is just really cool. So I'm going to play it and I'm hoping it's going to work.
This is a quick example of different types of video generators. We have used this software to develop e-learning courses for PHSA employed student nurses. These are interesting to watch, easy to develop, and easy to edit as well. They are also compatible with our Learning Hub system.
So this took me about maybe 30 seconds to do, but it's another really great, Synthesia is another great free tool that gives you a certain number. And then if you want more than that, then you have to get the subscription. But it's a great way to develop some online modules, some videos, again, really looking at what can they do in their pre-work and to help them consolidate. And then what can we do in order to engage them as a team and that kind of team-based learning approach. Technological tools also provide us with the opportunity to flip classroom approach, synchronous versus asynchronous, immediate feedback via polling systems, and a needs-based learning system. I'm not sure if anybody knows about this, but I want to give a shout out to BCM Mental Health. They did a great concurrent disorders toolkit, which really allows for that personalized learning through an active online platform. And I would say it increases our accessibility. We know in healthcare that our remote and rural communities don't have as much education support, and being able to do good virtual education can really help us engage and still support our staff that don't work in urban centers. And my encouragement is to take the leap. It's hard to use tools. It can be a little frustrating. It can be a little, we don't always have time to learn them all, but I encourage you to. I find every time I start, I get lots of great feedback from learners. And that's really why we're all here, is to improve our staff, who can then improve our patient care across the board. And that's all I've got. Thank you so much.
Amazing. Thank you so much, Simi. Really appreciate that. Due to time, we actually aren't going to go into Q&A. I do see a question for you in the Q&A section there by Christopher, one of our patient partners on the line. So maybe, Simi, if you might be able to connect with Christopher on FeedLoop and answer his question, that would be great. But this concludes our Pecha Kucha presentations. What a fantastic start to the presentations this week. Really an incredible demonstration of the breadth of digital health leadership happening in our province. We're now just going to invite you to complete a short feedback poll that will appear on your screen, just asking you a few questions regarding your thoughts on the session. And as you wrap that up, I'll also invite you to the next session, which is D2 Type, Empowering Lives with an Innovative App to Tackle Type 2 Diabetes, which you can navigate to via the panel on the left-hand side in FeedLoop. See you all there.